A critical care patient is one who is at high risk for actual or life threatening health problems and who requires intense and vigilant nursing care. These patients are usually physiologically unstable, they're at risk for serious complications, and require intensive and complicated nursing care. They require nurses with advanced clinical judgment. Many times they're in the ICU for various invasive interventions. Much of this is related to advanced technology being used. We are going to talk about hemodynamics, airway, and code management. Your goal related to these is adequate oxygenation to the tissues and the organs, as well as hemodynamic stability, which is based mainly on cardiac function, also known as perfusion. So our main concepts for this lecture are oxygenation and perfusion. First, I just want to go over oxygenation. FiO2 is fraction of inspired oxygen. As you know, room air includes 21% oxygen, therefore it's equivalent to an FiO2 of 0.21 or 21%. Supplemental oxygen is an FiO2 that's greater than 21%, which is room air, and you need to remember that supplemental oxygen is a drug. Therefore, you do need an order for it. Just remember, you need an order for oxygen because it is a drug. So when you give supplemental oxygen, you are raising the patient's inhaled FiO2 to something over 21%. The highest FiO2 possible is 100%. PaO2 is a sensitive and nonspecific indicator of the lung's ability to exchange gases with the atmosphere. So you know that you see PaO2 on ABGs, and the normal PaO2 is 80 to 100%. In patients breathing ambient or room air with a FiO2 of 21%, a decreased PaO2 indicates impairment in the gas exchange properties of the lungs. What this signifies is that there's a ventilation perfusion imbalance. PaO2 is a very sensitive indicator of gas exchange impairment. It can be reduced from virtually any parenchymal lung problem, and this can include asthma, COPD, and atelectasis that doesn't show up on a chest x-ray. So just seeing a reduced PaO2 is a non-specific finding because it can occur from any lung problem and only signifies a disturbance of gas exchange. So remember, gas exchange is the ventilation perfusion balance or imbalance in this case. So another thing you need to remember about oxygenation is that having a high FiO2 doesn't necessarily affect COPD hypoxic drive. I know that you think that every time you see a COPD patient, you shouldn't have them on more than 2 liters per minute. But you also have to remember, if the patient isn't ventilating, they need the oxygen. So if you need to put them on high flow oxygen, they get put on high flow oxygen, because we need to oxygenate the patient properly. If their CO2 goes up, we can always fix that, but we need to oxygenate the patient. So a high FiO2 doesn't affect COPD hypoxic drive, and the reason for this is a high FiO2 may raise the PCO2 in a patient with COPD. Is not because the extra oxygen cuts off the hypoxic drive. A modest rise in the PaCO2 occurs mainly because the extra oxygen alters the ventilation perfusion relationships within the lungs, creating more physiologic dead space. Remember, somebody with COPD has a ventilation perfusion problem. And so that is where this would come from, is the extra oxygen altering that relationship. And remember, it doesn't do it with everybody. So you can't assume that every COPD patient is going to have that hypoxic drive put down. So just remember, if the patient needs it, even if they're a COPDer, and that we need to make sure they're getting oxygen as they need it. All right, so we're going to talk about flow of oxygen, but first we need to remember that indications for oxygen therapy. There are four main indications for oxygen therapy. One is hypoxemia, low oxygen. Another, increased work of breathing. The patient is showing you an increased work of breathing. Also, increased myocardial work. We're having decreased cardiac output. That causes increased myocardial work, right? Somebody is having an MI. That's increased myocardial work. Somebody's in cardiogenic shock. That's increased myocardial work. The last reason that's indicated for oxygen therapy is pulmonary hypertension. All right, so now we're going to talk about the delivery devices. First, we're going to discuss, we're just going to go over quickly the low flow devices, which include nasal cannula. Those are put anywhere from 1 to 6 liters per minute. And the FiO2 provided by that, remember the FiO2 is a supplement above room air. So FiO2 with a nasal cannula will be anywhere from 24% to 44%. Then we have a simple face mask. That is usually set from 5 to 8 liters per minute. The FiO2 that will be received is 35 to 55%. You don't need to remember the specific FiO2s. I just want you to understand and think about the concept of it. So minimum flow with a face mask is going to be, has to be 5 liters per minute in order to flush the CO2 from the mask. So when you're talking about a face mask, minimal is 5 liters per minute, and it usually is set from 5 to 8 liters per minute. Face tent. A face tent is usually at 10 liters per minute. That has an open top, so there's a variable delivery because it mixes with the air. Many times patients can't tolerate face masks because they feel confined, so that's when a face tent may be used. A Venturi mask has variable liter per minute settings, anywhere from 4 liters to 10 liters per minute, and that will depend on the amount of FiO2 that is ordered. There's little colored pieces that go into the face mask to determine what a FiO2 rate is going to be, and that little colored piece will tell you how many liters per minute to set for the amount of FiO2 prescribed. Then we have the non-rebreather mask, which the oxygen is set at 6 to 10 liters per minute. You're going to get an FiO2 of 80 to 95% with a non-rebreather mask. You must remember that the flow into the non-rebreather must be sufficient to keep the reservoir bag from deflating upon inspiration. You should never ever see a flat non-rebreather bag. You need to see the bag expanded. There's also high flow devices, which is a nasal cannula, and the oxygen is set at 1 to 35 liters per minute, and this provides anywhere from 21% to 100% FiO2. Oxygen tanks must be handled with care. Don't leave them standing up on the ground or on the floor where they can be kicked. Keep them away from MRIs. Always, when you're traveling with a patient, make sure that you check the amount of oxygen in the tank before you start to travel, because you don't want to run out of oxygen during your transport of the patient. Think about signs of obvious breathing problems. If a patient's breathing is obvious on initial contact, for example, when you first see the patient on walking into the room, and it is abnormal. Normal breathing at rest is simply not obvious. One has to look very closely for chest movement to appreciate breathing. That would be normal breathing. 6 signs that may make someone's breathing obvious to the observer, and all are abnormal, are as follows. Flaring of the nostrils with breathing, which is typically seen in kids, but on rare occasions you can see it in adults. Tachypnea. Generally, for it to be obvious, the respiratory rate is greater than 24 breaths per minute. We also have noisy breathing, which includes wheezing, stridor, or moaning. People that have use of accessory breathing muscles, that includes the neck muscles, the intercostal muscles. You see that in kids and adults. Pursed lip breathing, which most often is seen in severe COPD. People that have Cheney-Stokes breathing. Cheney-Stokes breathing is in alternating periods of apnea with tachypnea. The apnea periods may last up to 30 seconds. So if you see signs of obvious breathing, that is abnormal. Those things that I just said, those 6 things, are obvious signs of breathing, and you don't want to see those. More information, if you need it, on oxygenation can be found in your essentials book on page 222. Airway management. Airway management purpose is to maintain patency. That's what we want. So artificial airways are used to establish an airway, protect the airway, and to facilitate mechanical ventilation. In other words, we want to maintain airway patency. Indications include upper airway obstruction, apnea, those that are at increased risk of aspiration, those that are ineffective at clearing their secretions, and those in respiratory distress. An oral airway, which is the rigid plastic curved piece, is used to keep the upper airway patent when it is at risk for becoming obstructed by the tongue or by secretions. This type of airway typically stimulates the gag reflex, so it's only used for patients with an altered level of consciousness. If they are gagging when this is in place, then a nasopharyngeal airway should be used. A nasopharyngeal airway is a rubber curved piece. It's also known as a nasal trumpet. These are also used to keep the upper airway patent. They're inserted through the nares and extend into the oropharynx. This type of airway does not stimulate a gag reflex, therefore it can be used in alert patients. Endotracheal tube, the long flexible plastic material with an inflatable cuff toward the bottom. These tubes are placed in patients that are undergoing a procedure that general anesthesia or patients needing mechanical ventilation. They're typically inserted through the mouth, though they can be inserted through the nares. It goes past the epiglottis and vocal cords into the trachea and down where the trachea bifurcates into the bronchi. After intubation, the cuff is inflated to help prevent air from leaking around the tube, as well as to prevent oral and gastric secretions from being aspirated. The size of the tube that's used depends on the size and age of the patient. A larger bore endotracheal tube reduces the work of breathing because of less airway resistance. Think about breathing through a tiny straw that you stir your coffee with versus one of those straws that you use for those really thick milkshakes. Preparing a patient for intubation, the nurse needs to make sure she has certain things ready. We want an ambu bag, also known as the BVM or bag valve mask. You need to have sedation available, oxygen, suction. The patient should be pre-oxygenated prior to intubation. Each intubation attempt should last no more than 30 seconds. If the physician is unable to obtain an airway within 30 seconds, he or she needs to stop and oxygenate the patient between attempts. After insertion of the ET or endotracheal tube, the cuff is inflated and placement is confirmed. Placement of the tube needs to be confirmed that it's above the bifurcation and not just going into the right lung. Confirmation is done using a CO2 detector or capnography, or both. You're also supposed to listen to be sure that there are breath sounds. You want to look and make sure there's equal rise of the chest. A chest x-ray is also completed to assure proper placement above the carina. The carina is where the bifurcation is. The nurse needs to chart the level of the tube, which is typically it's typically not called, but the tube has markings on it, and it's usually at 21 to 23 centimeters at the lip. That's how it would be charted. So if it's 22 centimeters at the lip, you would chart it 22 centimeters at the lip. ABGs are also used to assess the correct ventilation settings. So the ventilator needs to be set, and that will be done by the physician and ordered, and ABGs will be obtained to make sure that they're getting the correct settings on the ventilator. Tracheostomy tubes are typically for long-term airway support. They're inserted through a small opening in the neck directly into the trachea. This can be permanent or it can be temporary. They can be plastic or metal and also come in various sizes. Many tracheostomy tubes are cuffed like an ET tube, though some are not. Most tracheostomy tubes have an inner cannula that is temporarily removed for or during trach care. Early trach placement within 3 to 7 days is recommended if a patient is thought to need long-term ventilation or the airway for their airway. Having early trach placement results in fewer days on the mechanical ventilator. A trach tube is the only one that is placed surgically. Post-operatively, the nurse's priority is maintaining a patent airway. In the first 72 hours, the patient is at increased risk for tube displacement as well as tube obstruction. Think about that. In the first 72 hours, the patient is at increased risk for tube displacement as well as tube obstruction. Tube obstruction could be from secretions, it could be from bleeding, tube displacement because it needs to heal. There may be a small amount of bleeding, but you need to pay attention if it starts to get more than a small amount. It is essential to keep a manual resuscitation bag, or other words, ambu bag or bag valve mask, at the bedside. Also, a trach tube of the same size, one size smaller, and a trach insertion tray should be at the bedside for the first 72 hours. So a trach insertion tray at the bedside, a BVM or a resuscitation bag at the bedside, a trach tube of the same size, and a trach tube one size smaller should also be at the bedside of a new trach patient. These are pictures of the oropharyngeal airway. Remember, it can't be used in somebody with a gag reflex. It is hard plastic. You insert it sideways, you can see how it goes down over the tongue, but that needs to be turned sideways when it's inserted, and then once you get over the tongue, then you turn it down because you don't want to push the tongue down into the airway. So over on the right, you see the hard plastic oral airway, and then below that, you can see the soft plastic nasal airway, also called sometimes a nasal trumpet. And then there is a picture of a trach. That's the inner cannula on the top that's not inside, and you have the cuff there. You can see the cuff in the airway. So intubation, I talked about this some when I was talking about the airways and first talked about the ET tube or endotracheal tube. So just to reiterate, when you're preparing for intubation, a patient that needs to be intubated, we need to make sure that we have suction, an AMBU bag or BVM, resuscitation bag. We need oxygen, we need sedation, we need to make sure that consent has been obtained unless it's an emergent situation. During intubation, we need to pre-oxygenate prior to intubation. Each attempt must be less than 30 seconds. Our job is to assess oxygen saturation and watch the cardiac monitor. After intubation, the cuff is inflated, placement of the tube is confirmed. We need to listen bilaterally and look at expansion. We are going to use a CO2 detector and or capnography to make sure that it's in place. Also, a chest x-ray is obtained to confirm proper placement above the carina or above the bifurcation. You're going to chart the level of the tube using sonometers at the lip. An ABG will be obtained to assess for proper vent settings. Monitoring of the airway. This would be in ventilated patients. So we need to assure adequate oxygenation. We're going to look for signs of hypoxemia. What are we going to look for? We're going to look for their respirations, their respiratory rate. We're going to look at their oxygen saturation. We're going to look at their color. What other things might you look at to assure that you have adequate oxygenation? We're also going to make sure that tube placement is maintained. You have to be careful when you're turning the patients. If they're attached to a ventilator, you have to make sure you move the tubing with the patient because you don't want to pull the ET tube out. You're going to make sure that when you check your patient in the morning or in the evening or whenever you go on shift, you're going to know where the tube should be. 21 centimeters at the lip, you're going to go in and you're going to check and make sure that that's where it is. You're going to check for cuff inflation. On the outside of the ET tube, there's a little plastic pillow, I'll call it. It's just filled with air. If that is flat, then that means the cuff is probably not inflated because it needs to be puffed up to show you that the cuff is inflated. Your job also is to monitor tube patency. That means if they're coughing or if you can see secretions, they need to be suctioned. Oral care is huge for ventilated patients. We're going to talk about that more with ventilator-assisted pneumonia, but oral care should be done routinely. Subglottic suctioning, meaning suctioning of their mouth and above the epiglottis. Oral care means cleaning and brushing their teeth. Skin integrity. These people are usually sedated, so you have to make sure that you're turning the patient regularly. We need to maintain skin integrity. So if you have a patient that is intubated and they are speaking, if you can hear them speak, then the cuff is not properly inflated or it has an air leak. So the physician needs to be notified if you try to put air in to reinflate the cuff and the patient is still speaking around it, because that means that there's an air leak. Regarding suctioning, Patients should not be just routinely suctioned. You don't just suction Q2 hours or every 2 hours. You don't suction just every 2 hours. There are indications for suctioning for a patient that include you see visible secretions in the ET tube. The patient develops a sudden onset of respiratory distress. You see an increase in peak airway pressure. That is a reading on the ventilator. You will be introduced to that if you are working with patients on ventilators. But an increase in peak airway pressure, that means it's harder for the air to get through. You auscultate, and there are advantageous breath sounds in the trachea or bronchi regions. Another reason may be that you see a decrease in their SpO2. When you're suctioning, there should be no saline put into the tube. That was something that used to be done because it partly, I think, it made people feel good that when they suctioned, if they put some sterile saline in, they would always get something back. But that is known to cause infection, so you don't want to see anybody instill saline into the ET tube or into a trach. There's a few good questions on this little link here that's www.ati testing regarding airway management. So mechanical ventilation. It's the process by which the FiO2 is moved in and out of the lungs by a mechanical ventilator. It supports patients until they recover the ability to breathe independently. Indications for ventilation or for ventilator use include apnea, a patient who has the impending inability to breathe or protect their own airway. That, for example, could be somebody that is highly intoxicated. It could be somebody that has a drug overdose. It could be somebody that is going into shock, somebody that is septic. Also, people that have acute respiratory failure will need mechanical ventilation, those with severe hypoxia, and also those with respiratory muscle fatigue. That could be caused from something like Guillain-Barré syndrome. Respiratory muscle fatigue could be somebody that is an asthmatic that is having a hard time coming around. So they may get respiratory muscle fatigue. Could be a COPD or having an exacerbation. So those are some indications for ventilation. So a couple of modes for the ventilator are positive pressure ventilation. There are many more modes, but we're not going to talk about those. As I said, if you are working in an area where you're going to have patients that are critical on mechanical ventilators, you're going to be taught what you need to know. But you need to be familiar with these words for NCLEX, for one thing, and just to be familiar because you may hear them. So positive pressure ventilation. It's primarily used with acutely ill patients. What happens is during the inspiration, the vent pushes air into the lungs under positive pressure. There are two modes of positive pressure ventilation. They're volume ventilation and pressure ventilation. Volume ventilation is a predetermined, consistent tidal volume with each inspiration. The amount of pressure used depends on lung compliance or resistance. So its volume ventilation is based on the tidal volume or the volume used. The tidal volume is the amount of air that's delivered with each breath. The normal adult is 500 to 600 mLs tidal volume. Pressure ventilation has a predetermined peak inspiratory pressure. The tidal volume varies depending on the person, how much they take with each breath. So this is dependent on pressure. So in this type of ventilation, the nurse needs to assess the patient's tidal volume is adequate and not too small or too big. This amount will be indicated on the ventilator. Also, alarms will go off if the tidal volume is smaller than the set number the physician requires or bigger than the set number that the physician has wanted. You also need to assess the patient because you can see if they're taking really small breaths or really big breaths. And we need to make sure that the tidal volume is enough and not too much. So, with positive pressure ventilation, what I want you to think about is imagine breathing through a straw. Every time you breathe in, there's something, which is the ventilator, pushing more air in on top of what you're taking. So that would be positive pressure ventilation. So our goals with mechanical ventilation are to maintain alveolar ventilation. We want to correct any hypoxemia, and we want to maximize oxygen transport for these patients that are mechanically ventilated. All right, ventilator settings, words that you need to be familiar with. First, ventilator settings are based on each patient's status and their diagnosis. The settings are evaluated and adjusted regularly by the physician. First, FiO2, as I talked about earlier, is the fraction of inspired oxygen. It's the percentage of oxygen delivered to the patient above the amount of room air. This amount is changed depending on the patient's need. Many times, initial rates set in the ventilator are 50 to 60%, but can be higher or lower as needed for the patient. Changes are made based on their ABGs, or sometimes changes are made to help augment uptake of oxygen, such as increasing the PEEP that we'll talk about. But changes are based on ABG results. Many times they will also decrease the oxygen level or FiO2 percentage on the ventilator and see how the patient tolerates it. All right, tidal volume, as I told you just a minute ago, is the amount of air to be delivered with each breath. The normal adult at rest typically has a tidal volume of 500 to 600 mLs. Usually the vent is set at 5 to 8 mLs per kilo of ideal body weight. So it's what the patient would ideally weigh. Because if they're, say, 200 pounds over their ideal body weight, you wouldn't want to increase the amount of oxygen that they're getting anymore because their lungs aren't bigger just because they have more body weight. So, of course, things need to be taken into consideration, such as if the patient is a post-resection, meaning they had part of their lung removed, or other clinical situations such as ARDS when they want to promote lung protective strategies. So it's not just based on their weight, but many times that is where they would start from. All right, respiratory rate is set in many modes of ventilation. Sometimes the respiratory rate just goes by how many the patient breathes themselves. Sometimes the rate is set by the physician that they want a minimum rate. So if they are, say, breathing 8 and the physician wants 12 breaths, then the ventilator will make sure that they're taking 12 breaths per minute. All right, the PEEP, or the positive end expiratory pressure. This control adjusts the pressure that is maintained in the lungs at the end of respiration. So the PEEP adjusts the pressure that is maintained in the lungs at the end of respiration. This helps in reinflating collapsed alveoli and maintaining the alveoli in an open position and improving lung compliance. So the PEEP helps in reinflating alveoli that are collapsed, also helps to maintain the alveoli in an open position and improve lung compliance. PEEP may be increased when a patient is requiring more FiO2. So sometimes if the patient requires more FiO2, instead they will increase the PEEP and then they won't require more FiO2. We have to be careful though, because too much PEEP can cause barotrauma. In barotrauma, what happens is the air leaks from the alveoli into the pleural space, and this can result in a pneumothorax or pneumomediastinum. So PEEP can also be used to push the alveolar fluid, things like pulmonary edema, out of the lungs back into the circulation. A small amount of PEEP is normal, and a small amount would be 5 centimeters. All right, another thing about PEEP is we have to remember, or yes, you have to remember that sometimes when PEEP is increased, say they are set at a PEEP of 8 and the PEEP is increased to 10, the patient may experience significant hypotension. This is due to increased intrathoracic pressure that takes place, and that means that they're not tolerating the change. So if you see a patient that just has the PEEP increased and they experience significant hypotension, then you need to contact the physician or respiratory and get the PEEP put back, because the patient is not tolerating the change. So if the patient gets an increased PEEP and has significant hypotension, they're not tolerating the change and it needs to be put back. All right. PEEP, peak inspiratory pressure. A peak inspiratory pressure limit is the highest pressure allowed in the ventilatory circuit. Once that pressure is reached, the inspiration is terminated. So the PIP is the highest pressure that's allowed in the ventilatory circuit. So once the high pressure is reached, the inspiration is terminated. So if it constantly alarms, the patient is not getting the tidal volume that has been set, and a reason must be determined. So why is it trying to push the air into the patient and it's not going into the patient? So it needs to be determined so that the patient is getting the tidal volume that they need. All right, sensitivity. The vent setting of sensitivity is the amount of effort the patient needs to initiate an inspiration. So increasing the sensitivity decreases the amount of work the patient does. Decreasing the sensitivity increases the amount of work done by the patient. So if you're helping the patient to breathe more and they don't need as much effort, then you're going to increase the sensitivity. Decreasing the sensitivity means that the patient needs to do more of the work. Setting the amount of time, okay, we're talking about, inspiratory-expiratory ratio now. So setting the amount of time spent on inspiratory time versus expiratory time can vary depending on the patient's diagnosis and need. Usually there's a short inspiratory time and a long expiratory time. So many times the ratio is 1 to 2 or 1 to 3. This allows time for air to passively exit the lung, allowing increased venous return. Conditions when lungs have reduced compliance, that means that the lungs are stiff, like when somebody has ARDS or sarcoidosis, an inverse ratio setting is used. So the inspiratory time is equal to or greater than the expiratory time. So the ratio is 1 to 1 or 2 to 1, 3 to 1, 4 to 1. The inverse inspiratory-expiratory ratio improves oxygenation by expanding stiff alveoli by using longer inspiratory times. So the inverse inspiratory-expiratory ratio improves oxygenation by expanding stiff alveoli using longer inspiratory times. Thereby, it provides more opportunity for gas exchange and helps prevent alveolar collapse. Okay, ventilator modes. These are modes that are set by the physician, and the mode is chosen based on how much work of breathing the patient should or can perform. Generally, the mode that is chosen is controlled or assisted. So in controlled ventilation, the machine does the work of breathing for the patient. Assist controlled ventilation delivers a preset tidal volume at a preset frequency. The patient can breathe faster than what the vent is set for, but the patient cannot breathe slower. In synchronized intermittent mandatory ventilation, also known as SIMV, this delivers a preset tidal volume at a preset frequency in synchrony with the patient's spontaneous breathing. So in SIMV, the patient takes on more work of the breathing with this setting. Oftentimes, they'll put patients on SIMV when they're trying to get them weaned from the ventilator. Then we have pressure modes or pressure support ventilation. Well, pressure modes are when they're using positive pressure, which I talked about a little bit ago. But positive pressure is helping increase the pressure, keep the alveoli open. Pressure support ventilation, or PSV, is positive pressure being applied to the airway only during inspiration, and it's used in conjunction with spontaneous respirations. So positive support ventilation is positive pressure is applied to the airway only during inspiration, and it's used in conjunction with spontaneous respiration. Pressure-controlled inverse ratio ventilation combines pressure-limited ventilation with an inverse ratio of inspiration to expiration. Remember, I just talked about that, where inverse ratio means they have a longer inspiration, shorter expiration. This setting is indicated for patients with ARDS who continue to have hypoxemia despite having increased levels of PEEP and FiO2. Then we have continuous positive pressure, or continuous positive airway pressure, or CPAP, which is used with ventilated patients. It provides a continuous pressure through spontaneous inspiration and expiration. So there's a continuous positive pressure, whether they're breathing in or breathing out, and it helps keep open the alveoli. All right, now we're going to talk about ventilator ventilator alarms. These are extremely important. You can't just push the silence button and wait for somebody to come and take care of it. You need to assess why the ventilator alarm is going off and address it, especially if it's going off over and over again. Then there is something going on. Sometimes you have to take the patient off the ventilator and manually oxygenate the patient with a ambu bag. All right, so first is the high pressure limit alarm. The high pressure limit is the limit set above the peak inspiratory pressure. So the physician will choose what he wants the peak inspiratory pressure to meet, and the high pressure limit alarm will go off if they hit the peak inspiratory pressure. So what's happening is the ventilator is trying to push oxygen in to the patient, and it can't. So there's resistance to the gas flow. These can be from the patient coughing. It can be because the patient has a lot of secretions. There could be a bronchospasm. Patient is gagging. It could be because there's a kink in the tubing, or there's water in the circuit. Sometimes water will get into the circuit from condensation. So you need to pay attention to that. And you're going to, as the nurse, you need to assess for all of those. There are also conditions that the patient could have that can cause a high pressure limit. So if you've checked for all these things, coughing, secretions, bronchospasms, gagging, kinks, or water in the circuit, and it's still going off, then we must notify respiratory and or the physician, because there are conditions that can cause high pressure limit alarm to go off. If the patient has developed decreasing lung compliance, if the lungs are getting stiffer, if the patient has atelectasis or pneumonia or pulmonary edema. So then we need an MD assessment. Low pressure limit. The limit is reached because they're hitting the amount below the peak inspiratory pressure. So remember, high pressure goes off if it's trying to push in and it can't. Low pressure goes off if it's pushing and it's not meeting any resistance at all. So the ventilator is pushing air in, and it's not meeting any resistance whatsoever. So causes of this equal patient has been disconnected from the ventilator, or there's a leak in the system. It is meeting no resistance at all. High respiratory rate. This can be from anxiety, pain, fever, acidosis, or patient breathing above the set limit. So there's a set limit for the high respiratory rate, and if that alarm goes off, those things need to be assessed. Anxiety, pain, fever, acidosis. All right. Low exhaled tidal volume. This alarm is set to assure adequate alveolar ventilation is maintained. So low exhaled tidal volume is to ensure that adequate alveolar ventilation is maintained. So if this alarm goes off, causes include air leaks, decreased lung compliance, increased pressure alarm trigger is going off, and every breath is terminated early. So if every breath is terminated early, that means that they're not having adequate tidal volume. Then we have apnea. The apnea alarm activates when there is no exhalation detected for a set period of time. The vent will default to set apnea ventilations. So you need to assess the patient and the settings for accuracy. Example, if somebody is on CPAP, where they need to do all the work, remember CPAP, continuous positive airway pressure, the patient is doing the majority of the work. So maybe they have too much sedation on board and they are only breathing 6 times a minute, and the physician wants them breathing at 12. Then the apnea alarm will go off. You need to assess the patient and assess the settings for accuracy. Complications that can arise with mechanical ventilation. Many adverse effects may be difficult to distinguish from the patient's underlying diagnosis, but these are some of the things that you need to think about. Cardiovascular complications. You may see decreased cardiac output, and this is related to increased intrathoracic pressure, which causes decreased venous return, which thereby causes decreased preload, which is causing decreased cardiac output. So increasing intrathoracic pressure, especially when PEEP is in place, causes decreased venous return, thereby causing decreased preload, which thereby causes decreased cardiac output. Pulmonary complications that can occur include barotrauma, and this can be related to high lung inflation pressures with air leaving the alveoli into the pleural space, resulting in a pneumothorax. We also have volutrauma, and this is caused by delivery of large tidal volumes, which fractures the alveoli, allowing fluid and protein to seep into the lungs, causing a type of non-cardiac pulmonary edema. Ventilator-assisted pneumonia, we're going to talk about separately because that's a huge complication with a lot of money attached, because if people get VAP, then it won't be paid for to be fixed by insurance. Gastrointestinal, decreased peristalsis. This is more not from the vent itself, but more so related to immobility and sedation. So just keep that in mind when you have a ventilated patient. Okay, so ventilator-acquired pneumonia, or VAP. This comes from the IHI, or Institute for Healthcare Improvement bundle. Things you need to make sure that you do, make sure that you know to prevent ventilator-acquired pneumonia. Head of bed must be elevated 30 to 45 degrees unless it's medically contraindicated. Suctioning secretions in the oral cavity, or subglottic suctioning, it's called, is making sure that you're getting all the excess saliva out of the oral cavity. We want to prevent buildup of secretions. We want to drain the water that collects in the tubing in order to decrease bacteria buildup. Mouth oral care needs to be done regularly, maybe even every 2 hours. Mouth care is to reduce mouth's bacterial burden, but it also stimulates the flow of saliva. When oral care is not provided, it allows opportunistic organisms to flourish. You do not use tap water. You do not use tap water. You can use chlorhexidine and toothbrushes with suction are preferred. They have toothbrushes that attach to suction, and using chlorhexidine which is made. They make chlorhexidine for mouths. Using chlorhexidine and toothbrushes with suction is preferred. You can use sterile water so that you don't introduce any more bacteria, but remember, do not use tap water. Patient needs to be assessed daily for readiness for extubation. Making sure the patient has peptic ulcer prophylaxis. And also DVT prophylaxis related to the venous stasis. All right, chronic mechanical ventilation. Patients may be discharged to home or long-term care or hospice care with mechanical ventilators. They're not the same type of ventilators that are used in critical care units with acute patients. People that are discharged to home or long-term care need careful planning. They'll need care instructions for the vent and for the patient. So whoever will be caring for the patient, this education will include the patient as they are able to participate, as well as the caregivers. Settings and alarms are not as complicated as hospital ventilators, as I said. The available settings are very limited. Patients will typically be using a home type vent prior to discharge so that the settings are appropriate, as well as helping to educate the primary caregiver. Patients are at a reduced risk for hospital acquired infections when they go home with the ventilator. These patients will have tracheostomies, therefore they will need education related to care. Many will have home care in addition, but primary caregivers need to be educated as well related to the tracheostomies. So moderate sedation, also sometimes still called conscious sedation, is used to induce relaxation with minimal variation in the patient's vital signs. It's also used when cooperation is needed for a procedure. You've heard this before. We talked about moderate sedation or conscious sedation when we discussed somebody that needs cardioversion. Remember, somebody that is in rapid AFib, that is symptomatic, would need to be cardioverted, so they would get moderate sedation for that. That way they won't have a memory of it. In addition, they will get pain medication if it's going to be a procedure that is going to cause pain. Procedures that it is used for include endoscopies or colonoscopies, cardioversion, as I said, bone reduction. So if somebody has a fracture and they need to reduce it, meaning put it back into place or stabilize it, then they will use moderate sedation. Some dental procedures, moderate sedation is used. They use moderate sedation for cardiac catheterizations as well. Medications that are used include hypnotics, which are things like propofol or diprivan. Opioids are used for the pain. Many times the fentanyl is used. Benzodiazepines are also used sometimes instead of hypnotics. That includes Versed, also known as midazolam. Versed is the benzo that is used instead of propofol sometimes. So things you need to know: nursing responsibilities. So you must get together the equipment and supplies that are going to be needed. We need the ability to manage the compromised airway if it happens. So you need to make sure that you have oxygen at the bedside. You need a bag valve mask or for oxygenation and ventilation. You also need to make sure that you have suction at the bedside. Your responsibility is to be sure that consent was obtained from the physician performing the procedure. Make sure the patient is placed on a cardiac monitor. We need to have continuous pulse oximetry. You're going to monitor respiratory rate, especially because the medication's being given, heart rate, blood pressure, cardiac rhythm you're going to be watching. Also, you are going to have to pay attention to the patient's level of consciousness. Remember, I said sometimes it's called conscious sedation. It's because they will still answer questions, they can still follow instructions, they will not remember. They may say things that are funny, they may say things that are unexpected, they will not remember that either. So be careful when the patient comes out, and also be careful what you say, even though the patient is sedate and should not remember anything. Be careful of what you say because they may still remember. In addition to having the equipment that you need to have at the bedside, the stuff for oxygenation and ventilation, as well as the cardiac monitor, you need to have backup available. You need to have respiratory available in case something happens with the patient's oxygenation and ventilation. You also need to have ACLS support available. You might want to have a crash cart there, depending on what procedure is being performed, or one nearby. People that have ACLS experience typically are there, at least respiratory. The physician performing the procedure should be an ACLS certified. Not that you're going to check on that, but usually if they're performing a procedure that uses moderate sedation, there should always be someone there that is aware of it. So what happens is, as I said, it produces an altered level of consciousness. We need to make sure that the airway remains patent, but usually because it's an altered level of consciousness, the airway is not a problem, but it can become problematic. They also will respond to verbal and environmental stimuli. So remember those things that I said. Okay, now we're going to talk about hemodynamic monitoring. Hemodynamic monitoring is the measurement of pressures, flows, and oxygenation within the cardiovascular system or intravascular system. The purpose is to assess heart function, fluid balance, and effects of fluids and drugs on cardiac output. A single value that you get, like a CVP measurement or PA wedge pressure, a single value is rarely helpful. Trends must be monitored and evaluated, and you must look at the entire picture. That means also use your patient assessment along with the trending numbers that you're getting. Always correlate observation with data obtained. We're going to talk about arterial lines, which get systemic pressures, central venous lines, pulmonary artery wedge pressure, or PA lines. We're going to talk about cardiac output, cardiac index, and stroke volume. When we're talking about arterial lines, and CVP lines, and PA lines, all of those use transducers. So remember, I talked about transducers when we use ICP monitors. What it does is it converts the patient's signals to an electronic signal that makes a waveform that we can then interpret. Arterial lines, they're the gold standard for accurate blood pressure values when depended on for making therapeutic decisions in patient care. Arterial lines measure systemic blood pressure. Placement is typically in the radial artery, and occasionally it's placed in the femoral artery. Indications include cardiovascular instability that will typically cause fluctuating or unstable blood pressure. Use of vasoactive medications. This allows one to better evaluate the titration of the medication, because it's a continual reading that you get with an arterial line. You don't have to take a blood pressure every 5, 10, 15 minutes. Art lines are also used in patients that need frequent blood draws, because it can be taken from the arterial line without the patient being stuck repeatedly. For example, DKA patients who may need lab draws every 2 hours to follow the electrolyte changes that are going on. You really need to remember that when an art line is going to be put in, an Allen's test must be performed, and that is completed before the patient is cannulated for an art line to be sure that the occlusion by the catheter will not stop flow of blood to the extremity used. Remember, we have our radial and our ulnar arteries. So watch the little video here on doing the Allen's test, because if the Allen's test will tell you if the ulnar artery is going to make sure that the hand gets blood to it. So that needs to be done and documented when an art line is put in. We need to monitor for signs and symptoms of impaired circulation, specifically color, sensation, temperature, and movement. Arterial lines. They're the gold standard for accurate blood pressure values when depended on for making therapeutic decisions in patient care. Arterial lines measure systemic blood pressure. Placement is typically in the radial artery, and occasionally it's placed in the femoral artery. Indications include cardiovascular instability that will typically cause fluctuating or unstable blood pressure. Use of vasoactive medications. This allows one to better evaluate the titration of the medication, because it's a continual reading that you get with an arterial line. You don't have to take a blood pressure every 5, 10, 15 minutes. Art lines are also used in patients that need frequent blood draws, because it can be taken from the arterial line without the patient being stuck repeatedly. For example, DKA patients who may need lab draws every 2 hours to follow the electrolyte changes that are going on. You really need to remember that when an art line is going to be put in, an Allen's test must be performed, and that is completed before the patient is cannulated for an art line to be sure that the occlusion by the catheter will not stop flow of blood to the extremity used. Remember, we have our radial and our ulnar arteries. So watch the little video here on doing the Allen's test, because if the Allen's test will tell you if the ulnar artery is going to make sure that the hand gets blood to it. So that needs to be done and documented when an art line is put in. We need to monitor for signs and symptoms of impaired circulation, specifically color, sensation, temperature, and movement. Complications with arterial lines include accidental blood loss. This could be related to dislodgement, because especially when it's in your wrist or radial artery. To reduce the risk, make sure that Luer locks connectors instead of male to female slip-in type connectors are used for all connections. Also, immobilizing the extremity so that it doesn't become pulled on with movement. Infection is another complication. To reduce the risk for infection, we need to make sure that sterile technique is used for insertion, along with when we're caring for the site. We need to make sure that we use a closed system for blood sampling, because that will maintain the integrity of the system, where you don't have to open it every time to get blood samples. Impaired circulation is another complication and a big concern. So as I said before, monitoring for color, sensation, temperature, and movement of the extremity. Any sign or symptom of impaired circulation must be reported immediately and may be an indication for a catheter removal. This is another reason to be sure that an Allen's test is performed prior to insertion. Frequent assessments are essential. trying to keep it out from under the covers so that it can be assessed frequently just by looking at it is very important. All right, central venous pressure monitoring, or CVP. Placement of the CVP line is, well, it's a central line, and it's many times a pick, and it could be a basilic pick, or it's a central line placed in the subclavian vein or the jugular vein. The catheter is placed into the superior vena cava near the right atrium, while the catheter tip is in the superior vena cava near the right atrium. The CVP line reflects the pressure of the blood in the right atrium. It provides information on intravascular blood volume, right ventricular end diastolic pressure. So this is a measurement of right ventricular preload and reflects fluid volume of the patient. So the CVP reading is a measurement of the right ventricular preload and reflects volume of the patient. The normal CVP level, or the normal CVP level is 2 to 8. So an abnormally high or low measurement usually is associated with alterations in intravascular volume status or ventricular function. So remember, a CVP value alone is meaningless, but when used in conjunction with other clinical data such as breath sounds, heart and respiratory rate, any neck vein distension, urinary output, or EKG reading, it is valuable in managing and predicting clients' clinical course. So, an increased CVP may indicate right ventricular failure or volume overload. A decreased CVP is indicative of hypovolemia. So decreased CVP indicative of hypovolemia, and increased CVP is indicative of right ventricular failure or volume overload. All right, CVP line complications include infection, which may occur intravascularly or around the insertion site. Signs and symptoms include erythema, fever, elevated white blood cell count. Definitive diagnosis of infection is with blood cultures. Prevention of infection, routine dressing, and IV fluid tubing changes, as well as adherence to sterile technique during insertion and during dressing changes. Thrombosis. A thrombi may form as a thin layer of fibrin over the tip, or it can be a large clot over the tip. You'll see loss of a waveform. You may have inability to infuse or withdraw blood, which may be an indication that you have a thrombus. This must be reported immediately as the patient is at risk for a pulmonary emboli. Pneumothorax. This may happen on insertion if the introducer or the needle passes through the vessel wall and punctures the lung. A chest x-ray is obtained after catheter insertion to check for placement and assess for pneumothorax. Signs and symptoms of a pneumothorax include pleuritic chest pain, shortness of breath, and dyspnea, asymmetrical chest wall movement, diminished or absent breath sounds, and tachycardia. Pulmonary artery pressure, or pulmonary PA line, is used for the acute phase of patient care. The pulmonary artery diastolic pressure and the pulmonary artery wedge or occlusive pressures are sensitive indicators of the cardiac function and fluid volume status of the patient. Monitoring the pulmonary artery permits therapeutic manipulation of preload, thus maintaining cardiac output. So it is a central line. It is put in with sterile technique. It's also called a Swan-Ganz catheter, and it's used to measure the pulmonary artery pressure and the pulmonary artery wedge pressure, or it's also known now as pulmonary artery occlusion pressure. So indications for use include cardiogenic shock and people that are having CABG surgery or coronary artery bypass graft surgery. So there's 3 lumens in the artery. The distal lumen, which is, once it's put in, is located in the pulmonary artery and measures the PA pressure. You can also obtain blood for an SvO2 measurement. SvO2 is mixed venous oxygen saturation. SvO2 is an indicator of the balance between oxygen delivery and oxygen consumption. The proximal lumen of the Swan-Ganz catheter ends in the right atrium or superior vena cava. It measures right atrial pressures. This lumen can be used for the infusion of fluids as well. It is also used to inject solution to obtain the cardiac output measurement. On the tip of the PA catheter is a thermistor that measures the patient's core temperature. So that reading will always be on the monitor as well. So you always have the patient's core temperature. The third lumen is the balloon inflation lumen, and this is used to inflate the balloon that's located near the catheter tip. You inflate it with air. Filling the balloon with air causes the catheter to occlude the distal artery, which allows for measurement of the pulmonary artery occlusion or wedge pressure. It's an indirect measurement of the left atrial pressure. Do not leave the balloon inflated for an extended period of time because it can cause pulmonary infarction. Remember that insertion of this is done under strict aseptic technique by the physician. Complications of PA lines include infection, thrombus, pneumothorax, which I spoke about with CVP and arterial lines. Same thing. With PA lines, we have the worry of ventricular dysrhythmias, and these may occur during the insertion as the catheter passes through the right ventricle. When it does that, it may irritate the endocardium, which will cause PVCs and occasionally will cause VTAC. These typically resolve when it is in place, but you must always have emergency medications and emergency equipment on hand. Dysrhythmias can also occur if the line were to migrate back into the right ventricle, which may cause dysrhythmias. Pulmonary artery rupture or perforation. This is very rare, but a potentially fatal complication that may occur during placement or manipulation of the pulmonary artery line. Proper technique used during insertion and not overinflating the balloon when obtaining occlusion pressures or wedge pressures is extremely important. Pulmonary infarction. This will result from a loss of blood flow distal to the PA line. And it typically happens as a result of the line migrating distally into the smaller artery. Like when we blow up the balloon for the wedge or occlusive pressure, it just may happen spontaneously and will be like a spontaneous wedge pressure. So, prompt identification of this is essential. You may see a change in the waveform on the monitor, and that will indicate that you really need to check it. And then managing that can prevent a pulmonary infarction from occurring in the patient. So cardiac output. Cardiac output is the volume of blood in liters pumped by the heart in 1 minute. The cardiac output consists of heart rate times stroke volume, with the normal being 4 to 8 liters per minute. Stroke volume is the volume of blood ejected with each heartbeat. Preload, afterload, and contractility determine the stroke volume. So remember that preload is the volume within the ventricle at the end of diastole. It's actually the stretch, but the stretch is caused by the volume within the ventricle at the end of diastole. The pulmonary artery occlusion or wedge pressure reflects this in normal conditions. Diuresis and vasodilation decrease preload, whereas fluid administration will increase preload. Diuresis and vasodilation decrease preload, whereas fluid administration will increase preload. Afterload is the forces or pressure opposing the ventricular ejection. So increased afterload often results in decreased cardiac output. Just think about it for a minute. Cardiac output can be restored and myocardial oxygen needs reduced by decreasing afterload. Vasodilator therapy can decrease afterload. Contractility. Contractility describes the strength of the contraction. Let's go back and think about the drugs that can increase or improve cardiac contractility are positive inotropes like digoxin, epinephrine, dopamine, and calcium. Drugs that decrease cardiac contractility are negative inotropes like alcohol, calcium channel blockers, and beta-adrenergic blockers. There is no direct measurement for contractility. Increased contractility equals increased stroke volume and increased myocardial oxygen consumption. When would you not want this to happen? Think about that. When would you not want increased contractility, increased stroke volume, and increased myocardial oxygen consumption? All right, systemic vascular resistance, or SVR, is the opposition encountered by the left ventricle, the resistance of the systemic vascular bed. The pulmonary vascular resistance, or PVR, is the opposition encountered by the right ventricle, the resistance of the pulmonary vascular bed. These are the resistance to blood flow by the vessels. They both reflect afterload or pressure. The blood pressure is determined by the cardiac output and the opposing blood flow. Nursing management for invasive lines. Hourly site assessments and circulation assessments. You're looking for signs and symptoms of infection, assuring that blood flow is adequate to your extremity. Asking patient about any numbness or tingling in the extremity, pain at the site or in the extremity. These would be for arterial lines. Or if you had a basilic pick for your CVP line. You're going to assess for waveform changes, which could be dampening or heightening of the waves from the original baseline that you've seen. This can be caused by a clot, and this would include all of the invasive lines. Inability to flush a system could indicate a clot. This needs to be reported immediately, as a patient is at risk for pulmonary emboli or impaired circulation. Circulatory assist devices. They have several purposes, but the main purpose is to decrease cardiac workload, increase myocardial perfusion, as well as perfusion to the organs, and to augment circulation. The intra-aortic balloon pump, or IABP, is a temporary circulatory assist device used on the sick heart, and what it does is it reduces afterload via a reduction in the systolic pressure and by augmenting the aortic diastolic pressure, thus improving coronary blood flow. Some diagnoses that it's used with are patients with large MIs, those with cardiogenic shock. Sometimes it's used pre-op for CABG patients. It can be used intraoperatively or postoperatively or as a bridge to transplantation. So with an IABP, we have a balloon that's located in the descending thoracic aorta. Helium inflates the balloon at the start of diastole and deflates with the next systole. It is called counterpulsion because the timing of the balloon inflation is opposite the ventricular contraction. Initially, it's set at a 1-to-1 ratio. It inflates and deflates with every beat of the heart. When the balloon inflates, the blood is forced to the extremities and to fill the coronary arteries and main branches of the aortic arch. Rapid deflation then creates a vacuum, which causes aortic pressure to drop with reduced afterload. The left ventricle empties more easily and completely. So after somebody has an MI that affects the left ventricle, the muscle is not working as it should and therefore sometimes needs assistance. This assistance increases the patient's stroke volume and decreases myocardial oxygen consumption. The video here, the YouTube video, is a good explanation and shows a picture of the IABP and how the counterpulsion works. Ventricular assist device, VAD, sometimes it's called LVAD, left ventricular assist device, but there are RVADs and there are BiVADs. So a VAD replaces the patient's heart. It's typically used for patients in stage 4 or end-stage heart failure when conventional drug therapy is no longer working and they may be waiting for a heart transplant. Patients that have VADs, CPR is avoided as the device can rip away from its insertion site. The patients with VADs may not have palpable pulses, so part of your assessment is that you need to listen for the motor and assess for perfusion. Before patients are given VADs, they have lots and lots of education for themselves as well as their companions or people that will be helping them. This video about VADs is short and will help you understand how VADs work. Okay, rapid response teams. We talked about this in SIM, but why do they exist? They were actually implemented due to increased morbidity and mortality rates in the hospital, as well as increased failure to rescue, meaning that things were not caught in time. So by changes in the patient's catching changes, like increasing respiratory rate, tachycardia, trending, those types of things that go wrong are increases in failure to rescue, which increase in morbidity and mortality rates. So it exists as well for early treatment for hemodynamic instability, and it's to provide critical care expertise on the general nursing floors when it's needed. So who is involved? That is usually a critical care nurse. Could be sometimes they have float critical cares, or they come from the ICU, or they come from the ED. Respiratory is there. Physician resident or nurse practitioner is typically on the rapid response team as well. What do? They provide critical care interventions. They provide early treatment for hemodynamic instability. And as I did say, expertise on the general floor when needed. Okay, code management. Subtle signs of deterioration usually show 6 to 8 hours before a cardiac or respiratory arrest. What do you think those things might be? I think we've talked about them many times in many different lectures. Confusion, what's that telling you? Think about that. Tachycardia, increased respiratory rate greater than 28. How about a urinary output less than 50 cc's in 4 hours? How about trending changes in blood pressure? What are all those things telling you? Is that indicative of decreased perfusion or decreased oxygenation? Well, early recognition that something is going on takes care of that increased failure to rescue. We want to prevent what is going on or what might happen. They aren't breathing. They don't have a pulse. What are we going to do? Watch these videos. One video is how to do it the right way. The first video, just need to watch the first 9 minutes. Just 9 minutes. The second video is only 4.5 minutes, but that's how to not to do it. You also need to know about post-resuscitation care. Post-resuscitation care. Does the patient have a perfusing rhythm? What is a perfusing rhythm? You see the rhythm on the monitor. Do they have a pulse? Remember, what pulses are we going to check? We're going to check the core pulses, right? Central pulses. We're not going to check peripheral pulses. Does the patient have stable vital signs? If so, if the patient has a perfusing rhythm, has stable vital signs, is breathing properly or effectively, I should say, then the priority is to continue the present treatments as ordered. So if the patient has a perfusing rhythm, has stable vital signs, and breathing effectively, the priority is to continue the present treatment as ordered. So nursing in critical care. The biggest things for nursing in critical care, or nursing anywhere, is frequent assessments, because you need to catch those things that are going wrong early so that you can get on top of it and prevent something bad from happening. Monitoring trends, same thing as frequent assessments. You need to monitor the trends of the labs, you need to monitor the trends of your vital signs, and that way you can see if there's changes and anticipate what may happen. Initiating appropriate interventions and evaluating the outcomes. That's just general nursing care. You're doing that from the assessments, you're doing that from the trends, you're putting all the data together and then initiating interventions, and you're evaluating the outcomes. Is what you're doing making a difference with the patient? Are you getting the outcomes that you anticipated and wanted? Communication and collaboration with the team is essential in all nursing, but especially in critical care, because we have acute care patients and we need to make sure that we're communicating any changes with the whole team. Providing education. Education to the family, education to the patient. Make sure they know what's going on. They are scared. both the families and the patients are scared. So you need to make sure that you're telling them what you're doing, providing education, as well as providing emotional support to everyone involved. Okay, at risk. Critical care patients are at risk for complications related to immobility. They are at increased risk for skin breakdown. They are at increased risk for venous embolism. They're at increased risk for GI stasis. They're at increased risk for muscle breakdown. This all due to immobility. So range of motion, assign it to the family, whatever works. Making sure that you get the gut moving. Enteral feeding works best if they can't eat, because that gets the gut moving. Venous embolism, making sure that you have the socks on or the and DVT prophylaxis, making sure you're turning the patient regularly, getting them off the skin, making sure you're watching for any pink or changes in the skin. Complications related to invasive lines. They're at risk for increased risk for hospital-acquired infections. They're at increased risk for sepsis and MODS. Sleep disturbances. They're risk for complications related to sleep disturbances, which are related to frequent assessments that must be done in the ICU. The lights, because it's never dark. There's usually noise and there's usually a lot of alarms going off. Sedation. Remember, sedation does not cover pain. Pain is linked with anxiety and agitation, which are both linked with decreased healing. So make sure that they are covered for pain. Ventilation. With ventilation, the complications are they are at risk for VAP or ventilator acquired pneumonia. They're at increased risk for complications associated with intubation. Common problems you need to think of with your critical patients. Nutrition, inadequate, which increases morbidity and mortality. Adequate nutrition is essential to healing. Recognize the need to feed. Anxiety. The anxiety is related to unknown, so please remember that you need to let your patients know what is going on. Also, delirium related to the sleep-wake cycle because it's not consistent. Infection, we talked about that many times with many different things, especially all the invasive lines they have, so they're at increased risk for infection. Impaired communication, especially intubated patients, so make sure that you are paying attention to their communication, whether they have to use a communication board or they do. Just make sure that you're communicating with them. For nutrition, make sure that if they can't have enteral for whatever reason, that TPN is started. Sometimes pancreatitis, GI ischemia, peritonitis, paralytic ileus, those types of people or patients may need TPN.